Hi everyone, I'm Emma Eggleston, Dean of the WVU School of Medicine Eastern Campus. Welcome to tonight's Mini Med School. November is Lung Cancer Awareness Month. We are fortunate to have Dr. Rick Catlett, one of our pulmonary physicians here at WVU Medicine East, to take us through screening, detection, and treatment of lung cancer. This is particularly important for us here in West Virginia, as we have very high rates of smoking, of lung cancer death, and lung cancer that is detected at a late stage in the disease. Lung cancer is one of those cancers that is critical to catch early so that it can be effectively treated. Dr. Catlett will take us through some of the innovative technologies that we have available, including navigational bronchoscopy that helps us identify the causes of lung nodules, and also tell us about our multidisciplinary team that we have to help care for patients with lung cancer. Thank you, Dr. Catlett.
Good evening and welcome to the Mini Med School presented by WVU Medicine. I thank all of those who are here this evening, and I thank Dr. Eggleston for her kind introduction. I would like to speak a little bit about myself and why I feel that in many ways I am an excellent person to present a discussion to you about lung cancer awareness and how we at West Virginia University East work to go from screening for lung cancer to cure for lung cancer. I am a pulmonologist. I have been in the local area for over 30 years, and much of my career has been devoted to the treatment of lung cancer. Not only am I a pulmonologist, but my family has suffered directly from lung cancer, and so that I am aware of this disease from a personal standpoint. My grandfather learned to smoke during the First World War when he served in the trenches in northern France. At that time, smoking was actually promoted as a public health measure to decrease the risk of tuberculosis, which was thought to be spread by chewing tobacco, which had been commonly used earlier. In addition, cigarette smoking in the trenches served to help keep the troops alert. There was some camaraderie between sharing cigarettes, and it was very common for soldiers at that time to start smoking, which had never been done before. This led, 20 to 30 years later, the appearance in medical literature and recognition that lung cancer, which had been previously quite rare, was growing exponentially. As these individuals from the First World War continued to smoke, they continued to die in the 1950s, the 1960s, and, as occurred with my grandfather, in the 1970s of lung cancer. He presented with cough, slight amount of coughing up blood, and some dyspnea affecting his left side of his body. Chest x-ray was taken, which showed a lung mass. A bronchoscopy, which was relatively crude at that time, was done, and a type of lung cancer called squamous cell cancer was diagnosed. He went under very appropriate treatment with chemotherapy and radiation, but in spite of the best treatment at that time, he died within 6 months of diagnosis. I am firmly convinced that he had, if he were to have had lung cancer screening that we have available here in the Eastern Panhandle today, he would have lived a good 10 years longer, and I certainly would have enjoyed participating and getting to know him better at that time. Lung cancer is the #1 cancer killer in the United States. Is it important to us in West Virginia? Absolutely. As is shown on this slide, lung cancer has a high mortality rate. If you are screened you have a much greater rate of survival than those who are not screened. This slide is taken from a study done in Southeast Asia. It shows about a 60% improvement in survival in those who have lung cancer screening compared to those who don't. Studies done within the U.S. do not show as great a survival value, but it is at least 20%, and as data comes in, we think it is more. So screening for lung cancer saves lives, perhaps your life, perhaps a member of your family, such as it would have for my grandfather. West Virginia is particularly unique in that we are number one in the nation, unfortunately, for rate of cigarette smoking in adults. There are some years where Kentucky edges us out, but year in, year out, we're either number one or number two in rate of cigarette smoking. Cigarette smoking is the number one greatest cause of lung cancer in the U.S., which was recognized in the Surgeon General's report in 1964. If we want to prevent lung cancer, we should stop smoking. However, as most of us know, nicotine is addictive, cigarette smoking is addictive, and it is very hard to change habits. Therefore, for us as providers, we should encourage and offer mechanisms to help individuals stop smoking, but we should recognize that it's very difficult to do, and we should treat all people who are addicted to cigarette smoking with appropriate dignity and still try to help with their medical care as best we can. Lung cancer is dangerous and it is deadly because it is asymptomatic. If you have a small spot or nodule in your lung that is slowly growing, you will not recognize it until it gets to be a big size, at which time treatment is not as effective. This chart, which is a busy one and is hard to really show and explain, demonstrates that in Morgan, Berkeley, and Jefferson counties, we have a high rate of late-stage lung cancer, higher than in most other areas of the state, with the exception of the very center of the state and the southwest adjacent to Kentucky. Again, regions where there are high rates of cigarette smoking, and because lung cancer in early stages is asymptomatic, no one knows there without screening whether they have lung cancer or not. So therefore, lung cancer screening can help us make a diagnosis of early lung cancer at a stage when it is treatable and where we can have this marked spread in mortality. What is screening? All screening is a simple test in a population at risk that can pick up disease at an early stage. It's a test that's very sensitive, and what the best test that we have for picking up lung cancer at an early stage is a CT scan of the lungs. That CT is very good at picking up small nodules in the chest where they can't even be felt or heard or seen. And that information that there's a nodule there can lead to further workup. Screening is only done in populations at risk, so therefore the criteria for low-dose screening chest CT scans do include a significant smoking history, which is now defined as a smoking history of 20 pack years or more, 1 pack per day per year for at least 20 years. Lung cancer is more frequent as we get older, and the guidelines now say that those who are screened or can be screened should be between 50 and 80 years old. These guidelines have expanded over time. When the guidelines first came out, they were for those aged 55 to 77. As further evidence has come in, it has become clearer that the screening saves lives and that the range at which screening should be done, age range, should be expanded. So now the age range is 50 to 80 as compared to the earlier definition of 55 to 77. This slide does show that if you have been able to stop smoking completely and stop smoking for 15 years, you are no longer in the group in which routine screening should be done. This is because if you stop smoking, over time, your risk of developing lung cancer goes down quite close to that of someone who had never been a cigarette smoker. This further emphasizes the need for all of us to try to work to stop smoking if we can. It does show that the risk of lung cancer after you stop smoking still exists at higher rate than the rest of the population for 15 years. So there is no age at which it is too late to stop smoking. The CT scans are done on an annual basis. This is so that if a nodule that's very small on one scan is shown to grow, then we will know that there is a higher risk that that nodule is a cancer. In fact, we screen the nodules that are seen on CT scans as being low risk, indeterminate risk, or high risk for lung cancer, and that helps determine our recommendations for further diagnostic workup and direction of care. What I consider critical is that shared decision-making is part of this screening program. Before someone enters into the program, techniques of smoking cessation are discussed, and the rationale for why the program exists and how it will work is also discussed. So you, as a patient, are very dynamically involved in this overall process. The screening process, it's a program. It's not a one-time CT scan, but it's a commitment to work to prevent lung cancer or diagnose and cure lung cancer in yourself or your family member. Are we doing a good job in West Virginia in promoting and making sure that those who would benefit from this program are screened? Obviously not. At the present time, according to state statistics, only 4% of West Virginians who are eligible for screening are actually screened at the present time. This is an incredible number of lives within West Virginia who could be helped, could be saved, if we can promote this screening program. This next slide shows an example of what might be found on a screening low-dose CT scan. This gentleman entered into the program. He had a CT scan, which is low-dose CT scan. Low dose means that the amount of radiation is minimized to be the least amount of radiation necessary to do the job of picking up a pulmonary nodule. CT scan was done. This view is the head-on view looking at the left lung with the backbone here, left lung here. the nodule right here. This is a cross-sectional view straight through the body with the nodule shown in the left lower lobe adjacent to the aorta, backbone here, and ribs outlined here. I have chosen this scan for review because it shows a nodule quite close to a large vessel, so if you do a biopsy of it, we want to make sure that the biopsy does not cause bleeding, dangerous bleeding, from going into the largest blood vessel in the body. Ways of doing a biopsy are various. They are either by bronchoscopy and getting through airways a needle out here to biopsy, or potentially by having a needle come in by interventional radiologists between the ribs in this area right here and doing the biopsy in this region. We elected, in this case, to biopsy this nodule, which was 19 millimeters in size, quite close to the size of a dime. So a relatively small nodule, which would be early stage lung cancer. And we elected to use a newer technique that we have on the West Virginia East called navigational bronchoscopy. Navigational bronchoscopy in this newest form has only been available commercially for 2 years in the United States. It was introduced to this campus slightly over a year ago with one of our pulmonologists on campus, Dr. Philip Aguila, doing the first procedure here. To date, we have done over 100 of the biopsies using this, and we are very active in using this incredible technology. What is done? The computer takes the information from the CT scan and makes a diagram of a patient's airways. The computer is also able to show on the airways where the nodule is and can put a electronic marker where either a blood vessel or the edge of the lung is, so that we know which airway to go down as we come down from the large airway called the trachea, dividing out into the smaller airways, and have our bronchoscope go all the way out here, and then have a needle come with the depth of the needle insertion precisely adjusted so that dangerous areas of the body are not hit. This is what the equipment looks like. This is the scope itself, which is smaller than a conventional straw that you would get in McDonald's. Actually, it's about half the size of a straw in McDonald's. It's greater than the size of a spaghetti noodle. With this individual, we were able to go down, make a biopsy, and find out that this patient had a particular cancer called adenocarcinoma of the lung. He was able to go to our thoracic surgeons, and Dr. Abbas was able to take out one portion of the lung, basically the airway leading down to the nodule, and a small portion of the lung, and the patient has now been cured of his lung cancer. It was caught at an early stage, a stage which chemotherapy or radiation therapy would not be necessary, surgery, and that's it. This patient has also made a pact to stop smoking, so hopefully in 15 years of smoking cessation, this individual's risk of lung cancer would go down close to that of someone who has never been a smoker. This technology is incredible. It has been called by one of my colleagues who has a busy cancer clinic in Pennsylvania a game changer in how we do things. I feel very fortunate that we have this incredible technology here at Berkeley Medical Center. We do have a screening program. The screening program is designed to pick up lung nodules, and then appropriate workup at that point should go on. Important for all of us to keep in mind that not all lung nodules are cancer. Two examples exist here where this patient, now this was not actually from a lung cancer screening. This came from an incidental finding from someone who went to the ER, but it also shows how we can fit lung nodules that are incidental findings into our lung cancer screening program. This gentleman had gone to the emergency room after an automobile accident. They wanted to make sure that there was no significant lung injury. There was none. However, this ugly looking spot up there was found, and it looks for all the world as if it's a primary lung cancer. He went to bronchoscopy using this newer technique. We were able to get a needle very precisely up there, and we got lots of bacteria and white blood cells back from this. This was a lung abscess. This individual has been put on appropriate antibiotics, and that has gone away. So for me, this was a very rewarding case of an individual who had a nodule. We needed to make a diagnosis. We were able to make a diagnosis which was not cancer, get him on appropriate treatment, and also make strong recommendations that he take better care of his dentition, because the infection had come from his gums and had gone into the lungs. But as part of this process, this individual has made a pact to work at no smoking and has entered into the lung nodule screening program. This case right here is of an individual who was a heavy smoker up until 2019. At that point, the individual made a pact and was able to successfully get away from cigarettes, but because she has been a smoker within 15 years or has not stopped for 15 years, she was appropriate for entry into the lung cancer screening program. The first CT scan of the program showed these very small nodules. They are less than 4 millimeters in size. Usually, nodules that size, the best approach is to just monitor. Repeat scans have been done in 2019, 2020, and 2021. These nodules have stayed the same, and they are reflective of a very common type of infection that can occur around here. These are not lung cancer. They will stay there forever, but she still needs to be monitored until she has been a non-smoker for 15 years. So, lung cancer screening picks up nodules, but just because a nodule is found doesn't mean it's cancer. It means that the further workup that is appropriate to the situation needs to be done. Many of you will say, okay, what does the future hold? I don't want a biopsy. Are there any procedures that could be done that would help define whether my nodule that's been found on screening is lung cancer or not? In the future, we will have blood tests that help determine whether small particles of the lung nodule are breaking off and are in circulation and can give an indication whether that nodule is more likely to be cancer or not, and that might influence the decision to go to biopsy or not. Somewhere in the future, we will probably be able to use the bronchoscope to put a catheter that can deliver heat locally to destroy cancer cells in a nodule locally and go from minimally invasive surgery to surgery through the bronchoscope. But we're not there yet. So where do we stand? At the present time, in the eastern panhandle of West Virginia, we do have a comprehensive lung cancer program which incorporates screening for lung cancer. We have a group of excellent oncologists, members of the West Virginia Medicine Cancer Institute, directed by Dr. Wanko. We have extraordinarily well-trained thoracic surgeons. On this campus, the thoracic surgery program is directed by Dr. Kashyap, who is trained in minimally invasive lung cancer surgery, so that individuals who have lung cancer surgery are often in the hospital just for 1 day or 2 days with a very minimal scar compared to large scars that existed or were necessary 20 or 30 years ago. We have pulmonologists who are well trained in these newer techniques of bronchoscopic lung biopsy. We have excellent interventional radiologists who can very accurately biopsy nodules which are quite close to the surface of the lung if bronchoscopy is not needed. And we have a team of pathologists and radiologists and radiation oncologists who participate in this comprehensive program. We meet on a weekly basis for cancer board discussions, and we have specific pulmonary nodule conferences every other week with the goal of trying to ensure that you and your family get the best cancer care possible and best lung cancer diagnosis and care possible. I'm at the point of summing up my discussion, but there are several things that I would like to say. Medicine is a team sport. You can see how we operate in a multidisciplinary environment with many extraordinarily well-trained providers working to deliver excellent cancer care. But you have to participate. You have to be a team member as well. So at this point, what I would strongly encourage to you or to family members who are smoking, use resources that are available, such as the West Virginia Quit Line to aid in smoking cessation. I would encourage you to talk with your provider so that you could be referred to the lung cancer screening program if you are a cigarette smoker. You also do have the option of making a self-referral to this excellent program. Numbers listed and further information will be listed at the end of this presentation, but we have a wonderful nurse navigator, Erin Bauer, who helps keep everything organized, and you could call her directly for entry into the program. There may be some other questions that I have not addressed. Questions exist. What is the cost of the program? I can't tell you how much it would cost you to have the lung cancer screening. I can tell you that if you have Medicare or Medicaid, it is covered under your plan, and it is covered by most insurances. There often is a copay, but you would need to discuss that with your insurance plan. There may be other questions that you will have, and I will entertain any questions that we may have from the audience. I am also available and can be reached by if Aaron Bauer is contacted, and a question then can be forwarded to me, which I will respond to. I appreciate your attendance. I hope that this information has been useful, and I encourage your help in fighting lung cancer so that you and your family members, if lung cancer is found, it can be treated at an early stage and cured, and your family members will not have to suffer the problems of late-stage lung cancer as occurred in my grandfather. Thank you very much.